before actually going into recording the vertical dimension, there are certain terms which you should know. And these are vertical dimension at rest, vertical dimension at occlusion, and intraocclusal distance or freeway space. Okay, so intraocclusal distance of freeway space is one and the same. So we will see this. What is rest position of the mandible? What is occlusal vertical dimension at rest, vertical dimension at occlusion? Now, if you see, now you are sitting at rest. You know that there is a gap between your teeth, between the maxillary teeth and the mandible teeth when you're at rest, and that gap or that distance is called as freeway space. So when you occlude the teeth together, then when the teeth occlude and you measure a distance between 2 points, for example, the tip of the nose and the tip of the chin, that distance or the dimension is called as vertical at occlusion when the teeth are occluding. When your teeth are not occluding and the mandible is in the rest position, and you measure the distance between tip of the chin and the tip of the nose, that is called as vertical dimension at rest. So if you see the correlation between these three things, occlusal vertical dimension is equal to rest vertical dimension minus 3 millimeters. Why minus 3 millimeters? Because it is an average freeway space which we take. Okay, and we are going to see how you make use of this into deciding the vertical dimension of occlusion in the edentulous patient. So this is another important definition which you should know about the rest. What is rest position of the mandible? It is a postural position of the mandible when an individual is resting comfortably in an upright position and the associated muscles are in the state of minimal contractual activity. Now, what is this associated muscles? You know the muscles which elevate the mandible and muscles which open the mandible. So these group of muscles, these two groups of muscles should be in a state of minimal contractual activity. And the mandible will be suspended because of this. And that position of the mandible is called as raised position of the mandible. And this position we are going to take help of in deciding the vertical at occlusion by calculating by the equation which I just told you. Now, there are certain controversies about this, and some people may say that there may be variations in the rest position because patient, it depends on the patient. There are some local factors like pathologies, and patient may not give the proper rest position, and you cannot judge clinically whether the rest position of the mandible is achieved or not. So there is a definite instrument which can be used and which give you an idea about your rest position of the mandible is achieved or not, and that is called as electromyography. But electromyography is not used clinically, routinely everywhere. So there is a dilemma, like vertical dimension, there is no scientific proven reliable method. So what you do is you use one method for recording and you verify with the other method. So there may be variations in the rest position, but if you use another method to verify it, you come to know that no, it is not right. So if you use 2 methods or 3 methods at a time, that will give a better idea about the correct vertical dimension of occlusion. Now, coming to the methods which are used for vertical dimension, as you all know, they are classified into mechanical methods and physiologic methods. The mechanical methods are actually not the methods, these are the guidelines. So don't use these as methods for recording the vertical dimension, but these can be used as guidelines for after you record the vertical dimension. So the methods which are used clinically, they are physiological rest position, phonetics, swallowing, and tactile sense. So these are the important physiological methods which are used clinically for deciding the vertical dimension of occlusion. So the next step is you're going to take help of raised position of the mandible in deciding the vertical dimension, and this method is given by the Niswonger, as you all know. So what you do in this is you may put the maxillary record base in the rim. Don't put the mandibular record base in the rim in the patient's mouth at this point, and you ask the patient to say certain words with ending with M, for example, Ram. And when the patient is relaxed after saying Ram, you measure the distance between the 2 points, which is one is marked on the tip of the nose and one is marked on the most prominent point of the chin. And you measure it with a divider and you take 3 consecutive readings for this. Why 3 consecutive readings? Because as I told, every time patient may not give the same, patient may not give the correct vertical dimension, raise position every time. So you measure this raise position, you guide the patient into raise position, or you ask the patient to say words with Ram ending with M, and you measure the distance between 2 points, and that is raised vertical dimension. And you take this 3 times, you should get consecutive readings every time. And then after you take this reading, what you're going to do is do some calculation. So if you reduce 3 millimeters from the rest position of vertical dimension at rest, you're going to get the vertical dimension occlusion. Now, for example, if this is 6 centimeters and you minus 3 millimeters, you get 5.7 centimeters as occlusal vertical dimension. So, and then you're going to put the mandibular rim in the patient's mouth, and you're going to adjust in such a way that when you measure the distance between the same 2 points, that is tip of the nose and the tip of the chin, it will be 3 millimeters less than what you got at the vertical at rest. So that is going to give vertical dimension at occlusion. And the 3 mm space which you give is the freeway space or the intraocclusal distance. Now, when you adjust the mandibular rim according to the maxillary rim, you ensure that there is a uniform contact all over. It should not be that there's open bite or there's a gap posteriorly on one side or both the sides. It is very important that when you adjust finally the vertical dimension of occlusion, your rims should be evenly touching to each other, the upper, the maxillary and the mandibular rims. So when you adjust this vertical dimension at occlusion, then you can ask the patient to verify it. You can ask the patient to say again Ram, and when you just part the lips apart, you will find this space in between the maxillary and mandibular rims, and this is called as freeway space when the mandible is into raised position. Now you have recorded the vertical dimension of occlusion with the help of Nisonger's method, but you're going to verify it with some other method, and you're going to use closest speaking space, Silverman's closest speaking space. Now, what is this Silverman's closest speaking space? When you say yes or words with containing sir, for example, exust, sasust. So when you observe the patient while the patient is saying yes or sir, what happens is even you can observe yourself, the lower incisors come very close to the maxillary incisors, but they don't touch. So there is a slight gap between the maxillary and mandibular incisors around 1 millimeters, and that is called as Silverman's closest speaking space. So now when there is a wax rim in the patient's mouth, there is a dentulous patient, so obviously there are no teeth. So what you're going to observe is when the patient is saying sir or yes, the words containing sir, the mandibular rim will come very close to the maxillary rim, but it will not touch. So it will just come very close, but it will not touch. And that will ensure that your vertical dimension is not more excessive or is not too less. Okay, so that both ways you'll come to know about the vertical dimension. So this is an important clinical step to follow after you record the vertical dimension of occlusion by Nisonger's method. Always check with the Silverman's closest speaking space. Now there are some other guidelines also which will tell you where your vertical dimension is right and into the range which we want. So the one other important clinical tip is if you see the lower wax rim in the patient's mouth, and if you see ask the patient to slightly open and see the corner of the mouth, and relation between the corner of the mouth and the wax rim, the lower occlusal plane should be 2 millimeters below the corner of the mouth. So that is very important. So if it is there anteriorly and posteriorly, if you see and mark this retromolar pad area in the patient's mouth, the wax rim should be at least at the 2/3 of the retromolar pad area. If you see the retromolar pad area, and if you see from the sides, and if you divide this retromolar pad area into 3 parts, that is one here, the lower, middle, and upper, your wax rim should come at the level of somewhere here. Okay, maybe half to 2/3 of the retromolar pad area. So posteriorly, you see this landmark for deciding the occlusal plane, and this is very important. So after you record the vertical dimension, you check additionally with the Silverman's closest speaking space, and then you're going to check the lower rim in the patient's mouth. I'm going to check anteriorly the corner of the mouth and its relation with the mandibular occlusal plane, and the relation of retromolar pad area and its relation with the occlusal plane. So that will give an indication where you have got the vertical dimension right. Now, what is the significance of this vertical dimension? Like, if it happens in the exam that there is no freeway space and you recorded the vertical dimension wrong, like there is too much of vertical dimension for occlusion. Now, the examiner may ask you the questions, what is the significance of increase in the vertical dimension? What are the problems patient will face? So you should be ready with the answer. What problems the patient will face? There will be constant clicking of the teeth, because always the teeth will be touching during the function, and that is going to cause constant noise, the teeth coming in contact always. And because the teeth are coming in contact always, there will be constant force or the pressure on the underlying foundations, and there could be resorption of the foundation of the ulnar ridges faster than usual. So this is very important, and there may be some problem with the TMJ. There will be discomfort. Patient will not be able to speak. Patient will not be able to swallow. Okay, so these are the problems which patient will face if you give too much of vertical dimension of occlusion and there is no freeway space. Now, sometimes it may happen that you give too much of freeway space, or you give less vertical dimension of occlusion. So if you see such patients, what is going to happen is when the patient is using the dentures and patient closes, you see this here, that the height of the face, the lower third of the face is reduced too much. This is because of too much of freeway space which is given. Now, what are the consequences of it? When the freeway space is too much or the vertical dimension of occlusion is too less, what is going to happen is there's going to be less masticatory force the patient can apply. So the muscles has to overclose the jaw to bring the teeth into contact with each other. So that is going to reduce the power of the muscles. So if you have heard of the Bose biometer as one of the methods of recording the vertical dimension, Bose biometer is going to record the masticatory force when the patient is asked to clench together with the rims together. And when the masticatory force is maximum, that is considered vertical net occlusion. So that is an indication where your vertical dimension of occlusion is right. So what is going to happen when there is too much of freeway space or too less of vertical dimension of occlusion is patient is going to have less force while masticating. Then there may be some cheek biting on the sides. The cheek may be coming in between. The appearance, as I showed in the picture here, the appearance may be like this. The lower lower third of the face is reduced. The height of the lower third is reduced. And there may be again the problems with the TMJ. Okay, so these are the problems which you face when the patient faces when there is a decrease in the vertical dimension of occlusion. So you should know this because these are the questions which are asked chair side. Now there is another way to know where your vertical dimension is right, but this is after you mount the cast on the articulator. When you mount the cast on the articulator with the rims and you remove the record bases and the rims and you observe the cast from the side, the mounted cast on the sides, you will observe that the maxillary ridge is parallel to the mandibular ridge. And that's an indication that your vertical dimension of occlusion is right. So this is another checkpoint which you can use when you mount the cast on the articulator and you see from the side where your ridges are nearly parallel to each other. Now, there may be some confusion in the students, like sometimes the examiner asks you, what is the difference between closest speaking space and freeway space? So sometimes students get confused. What is the closest speaking space and what is freeway space? So basically, Silome has given this closest speaking space and it is based on phonetics, like during function. When the patient is speaking, you observe the patient when saying yes sound or the s sound, and the lower teeth will come very close to each other, but they don't contact each other. It will be around 1 millimeters, and you can actually measure it in the dentulous patients or at the stage of trying when you arrange the teeth. But the freeway space is actually based on the rest position of the mandible. So when you are at rest, there will be a gap between the maxillary and mandibular teeth, and that gap of around average distance of 3 millimeters between the upper and the lower teeth, and it is used as a guide to arrive at a vertical dimension of occlusion, which you're going to use as one of the methods, and that method is given by Nies-Wonger. So one is static and one is dynamic. So you should know the difference between closest speaking space and the freeway space.